All right, let's talk about blood pressure. I know, you've heard the term a million times, but today we're going to finally decode it. And listen up, because this isn't just some random lecture topic. This is a guaranteed NCLEX priority, and it's something you'll be checking, charting, and making decisions about every single shift. So let's get this concept totally nailed down together. You got this.
So yeah, we've all seen it, 120/80. It's like the magic number for health, right? But what are we actually measuring? What is happening inside the body to create those two numbers? Think of it less as a number and more as a two-part story about the incredible work your heart is doing, second by second. Let's break that story down.
Okay, first up is the top number, the big one. This number tells the first half of the story, and it's all about power. It's called systole. Here's a little memory trick for you. Systole starts with an S, and so does squeeze. That's what this is all about.
So systole is the heart's action phase. It's the moment the heart muscle, specifically those super strong lower chambers called the ventricles, contracts. Imagine your heart is a big sponge soaked with blood. Systole is when the heart squeezes that sponge with everything it's got, forcing all that blood out into the arteries to go supply the whole body. It's the big power stroke.
And that powerful squeeze creates this massive wave of pressure inside your arteries. Look at that peak on the graph right there. That's it. That's the moment the blood surges out, stretching the artery walls to their limit. This highest point of pressure created by the heart's contraction, that is your systolic pressure.
And that peak, that absolute max pressure from the big squeeze, gives us our first number, 120. So, pause here for a sec. When you see 120, what are you thinking? You should be picturing that powerful heart muscle contracting, pushing blood out to the whole body. You nailed it. That's systole.
Awesome. But hey, the heart can't just squeeze forever, right? It has to relax, reset, and get ready for the next big push. And that brings us to the second number, the bottom number. This is the story of diastole. Think of it as the heart's downtime.
So, diastole is when the heart muscle relaxes. The squeeze is over, and now the chambers are dilating or opening up to fill with blood for the next beat. Now, you might think, okay, if the heart's relaxing, shouldn't the pressure just plummet to zero? But it doesn't, and the reason why is actually pretty brilliant. It's the secret to keeping you alive between heartbeats.
The hero of this part of the story is your arteries. Now, don't think of arteries as just simple pipes. They're not. They are amazing high-tech hoses with thick, muscular, and super elastic walls. They're built this way for a reason, to handle that powerful systolic surge we just talked about.
Here's the key takeaway, guys. During that big systolic squeeze, the arteries stretch out like a balloon being filled with air. They absorb and store the energy from that wave of blood. Then, when the heart relaxes during diastole, the elastic walls of the arteries recoil. They snap back. And this recoil is what keeps pushing the blood forward, maintaining a constant pressure. This is so important. It means your brain and kidneys get continuous blood flow, not just a little squirt with each heartbeat.
And that constant pressure, the pressure that's left from that elastic recoil while the heart is resting and refilling, well, that gives us our second number, 80. So, quick quiz. What's the 120? That's the peak pressure from the squeeze. And the 80? That's the resting pressure from the artery's elastic rebound. Perfect. You've totally got the basics.
Okay, so we've got a powerful pump and these amazing elastic pipes. But the body is smart. It needs a way to control everything, to fine-tune the pressure and decide where blood needs to go. That's where resistance comes into play. Think of it like putting your thumb over the end of a garden hose.
Don't let the scary-looking equation fool you. It's actually super simple. Mean arterial pressure, think of that as just your average blood pressure, is determined by two things: cardiac output, which is just how much blood the heart is pumping out, and total peripheral resistance, which is how squeezed or clamped down your blood vessels are. If you increase the flow, or you increase the squeeze on the pipes, the pressure goes up. That's it.
And the main players in changing that resistance are these tiny little vessels called arterioles. I want you to think of them as the gatekeepers. They have muscular walls that can either clamp down, which we call vasoconstriction, or relax and open up, which is vasodilation. By doing this, they can direct more blood to your muscles when you're running or to your gut after a big meal, all while keeping the overall system pressure stable. So many of our blood pressure meds work right here on these little guys.
So all that physiology is awesome. But let's get down to the bedside. How in the world does a simple cuff and a stethoscope let us eavesdrop on this whole amazing process? Let's break down the skill itself. This is what you'll actually be doing. The sounds you listen for have a fancy name, Korotkoff sounds. And here's a common mistake. These are not your heart sounds. They're not the love-dub. These are the sounds of blood moving through the artery. Specifically, it's the sound of turbulent blood flow. Think of a fast-moving river hitting rocks. That choppiness makes a sound. Smooth flow is silent.
The process itself is pure genius. First, you inflate that cuff until it's so tight it completely squeezes the artery shut. No blood flow means silence. Then you start to slowly release the pressure. The second the pressure in the cuff drops just below the patient's peak systolic pressure, a tiny jet of blood is finally strong enough to push its way through. And what does that create? Turbulence. And you hear that very first tap, that's your systolic number.
Okay, NCLEX alert. This is huge. You absolutely have to know this. That very first sound you hear when you're deflating the cuff, that first tap, is the systolic pressure. You keep letting the air out and you'll keep hearing the tapping. The moment the tapping stops and it goes silent again, that is your diastolic pressure. Why? Because now the cuff is loose enough that the artery is wide open and the flow is smooth and silent again. First sound, systolic. Last sound, diastolic. Burn that into your brain.
Okay, we've gone from the big squeeze in the heart all the way to the sounds in your stethoscope. Let's zoom out one last time and connect all the dots. Why does this single measurement matter so much for our patients?
It's all about this pressure gradient. It's a simple concept. Things flow from high pressure to low pressure, just like water flows downhill. Your blood pressure is highest right when it leaves the heart, and it gets lower and lower as it travels away, until it's almost zero when it gets back. This downhill slope is the driving force that pushes blood into every tiny capillary in every single part of the body. This is perfusion.
And that driving force is everything. It's what delivers oxygen to the brain so your patient can be alert and oriented. It's what delivers nutrients to the kidneys so they can make urine and clean the blood. It's what carries away waste products. Without adequate pressure, you have no perfusion. And without perfusion, well, nothing works. Blood pressure is literally the engine of your patient's internal transport system.
So let's do a super quick rapid-fire review. What phase is the big squeeze? Systole. What phase is the heart relaxing and refilling? Diastole. The first sound you hear is systolic. The last sound is diastolic. You've got it. So the next time you take a patient's blood pressure, you'll know you're not just writing down a number. You're listening to the story of a powerful pump and an elastic rebound. You're measuring the very force that's keeping them alive. You are listening to the rhythm of life.